Good morning, everybody, and welcome to Communication and the Clinical Interview. Today we played a little game, a communication game, and warmed you up to get you on the track of what is therapeutic communication. But if I could sum it up into one word, does anyone know what that word might be? Can anyone sum up therapeutic communication in one word?
Helping?
It is helping. It is helping. Okay, normally I'd like to play hangman, but I don't think we have time because we're filming it here. So I'm going to sum it up for you in one word, and this might help you when you answer some questions. Okay, neutral. It's neutral. And that's our whole goal in the hospital as a nurse in the psychiatric setting, is to be neutral. Neutral in attitude, neutral in dress even. We don't want to be too loud either one way or another. We want to be neutral. We want to be there as an empty vessel, sort of, as that therapeutic tool. It's not empty as far as our knowledge base goes, but we want to be non-judgmental. We want to really listen to our patients, and we want to go in with a neutral stance and a neutral being, okay? And the statements that we make are neutral, to the client. Okay, so let's begin. Okay. So if we look at this communication process, the first slide here is just simply communication 101. Okay, there's a sender, a receiver, a message that's going from one to the other, and then feedback that's coming around. So it's a loop. There's a communication loop, and that's what this slide talks about. And also we're going to talk about the way that a message can be sent can be several different ways: auditory, visual, tactile, smell, or any combination of them. So it's not just what you say. It's all about other things as well. How you say it and how you look. Okay, your facial expression and things like that. Social relationships are different from therapeutic relationships. As you were playing your game, you saw that maybe some of the answers that you thought were reassuring were things that we would say in a social setting. But in a therapeutic setting, we're not going to try to reassure a client. Really, we are going to try to listen to what they're saying and experience with them what they're experiencing is more what our goal is going to be. Therapeutic communication is actually evidence-based. So there's a tool that we use to develop this skill, and you'll be using that and have already used it thus far, and it's called the process recording. Okay, so that's the tool that you use that helps you become more proficient in therapeutic communication. So if we look at this slide, it talks about the psychiatric rotation, that you will see how important therapeutic communication is. But in any distressing situation, you'll see how important it can be. I can't tell you how many students I have even that say they're sitting for a patient. And, "Oh, Mrs. Moore, I used the therapeutic communication that you said, and it was so helpful." Or even in the ER setting, last semester I had a student who was working in the ER as a student worker saying how patients usually were ignored that had mental health conditions, but he was able to go in and try some new things and try therapeutic communication, and he felt that went so much better than having the patient ignored with security standing next to them in a stigmatizing manner. So it can really be helpful to improve the quality of the experience for the client in many settings, especially in the emergency room. If any of you are going to be in the emergency room, that's often a place where a psychiatric client will come in initially. Okay, this is a question that a lot of students have. What about what I say to them? I don't want to hurt them. I don't want to get them angry. Okay, so a lot of people have this question. This is the thing. Even if you didn't have therapeutic communication or any therapeutic communication class, but you went in with an attitude of caring, acceptance, that goes a long way. So you're going to hopefully have that ready, and then in addition, you're going to be developing some skill to go with that. But genuineness is really important. Someone can tell if you're genuine. A psychiatric client can tell if you really care about them. And that's going to go a long way. The other thing is that consider the adult as far as their ego development goes. Okay, their ego is fully developed. So one thing that you say to them is not going to have a long-lasting impact, like it would a child. If you can think back to your childhood, there may have been something a person said in your past that did have a big influence on you, and you can still remember it to this day. Okay, but as an adult, we're more resilient. Okay, things can fall off much easier than they do. So yes, you may say the wrong thing, and actually you will. You're going to say the wrong thing. That's fine. That's what the process recording is for. You put it on the process recording and you find out how to weed that out of your communication. And don't worry about making a mistake. Your genuineness is going to cover for that. Remember, 90% of the communication is nonverbal. So a lot of times it's how we say it. If we have a new nurse that was on a psychiatric unit that wants to effectively communicate in a therapeutic relationship with a patient, so I talked a little bit about what are some of the things that will help, but what do you think that might help you? Planning for communication, it's going to be your first day of clinic. What kind of things are you going to think about before you start interacting with the patient?
Be positive.
So your attitude, mental attitude, readiness of mental attitude. Sounds good. Another thing that's important is to have a goal. Okay, so your first goal in the psychiatric setting is going to be to establish a rapport. So you're going to want to establish a relationship, a positive relationship with a client. And how you probably best will do that is to initially have short interactions throughout the morning. Okay, you can't just sit down with someone and get into a heavy conversation. They have to get to know you a little bit. So during the morning breakfast, you say hi, you go in, you make yourself visible. Even you can sit down with some clients sometimes and have a conversation with them. Make yourself visible. Going to groups, okay, they see you in groups. Then that's a good point. Something in group might have stuck with you, and later on you can say to the patient, oh, in group I heard you mention this, and then start a conversation with them. So making yourself visible, making yourself available, having a goal, developing rapport. And then if there is a specific thing that you want to communicate, just being clear and concise about that. If you have a goal of teaching the client about something, being prepared for that as an example. All right. There are factors that on both sides affect communication. Okay, so we have some personal factors that may affect our communication. The first day that you're going to be in the psychiatric clinic, how do you expect you might be feeling? So a little bit of anxiety, okay? So that's going to affect the way you communicate with someone, how the client is feeling. So just our simple moods throughout the day can affect the communication process. What about our personal biases, our stereotypes, things like that? How about our level of knowledge in our experience? So those are personal factors that are going to affect that. For the client, same thing. What are their experiences? So a lot of times things that come into the interaction may have nothing to do with us per se. It may have stuff to do with our past. So when you're thinking about personal factors, I want you to consider not taking things personally. That's one thing you don't want to do. If a client is angry, if a client is anxious, 99.9% of that has nothing to do with you. Okay, so first step, don't take things personally. Environmental factors. We are well aware of the environmental factors in our building here that make learning or interactions uncomfortable. Example, temperature. Are we not always struggling with the temperature in this building? Okay. So luckily our air conditioner is working today.
I have attachment for my posterior vitreous, and I need to wear this.
So you could see me. Yeah, so that's another thing, right? So vision, these are types of things that you're talking about. So that's a personal factor for you. And so another thing in the environment is privacy. That's a challenge sometimes in the psychiatric setting. So for an adult, we kind of want to pull away either in some corner of the room, or even maybe we can go out in the hallway, bring a couple of chairs out in the hallway and have a little bit of privacy. They probably don't want everybody hearing everything they have to say, especially if they want to have some therapeutic communication with you, the student. Okay, for kids, it's especially important not to discuss anything personal in front of other children, because there's a factor of taunting and things like that that could happen from that. So you have to be especially careful with adolescents and children not to discuss the reason why a person is in the hospital or any private information. Okay, for an adult, it's up to them what they want to share. They could be in groups and share deep processed feelings and deep processed happenings, events in their life. That's their choice. They can do that, but we don't do that for them either. Okay, so we're not going to bring up their factors. Relational factors. So when we're in a relationship, provider to client, we have to remember that we are in not really necessarily what we would say an equal relationship. You know, we are in one of where we are somewhat a little bit above them. So we have to really treat them with respect and dignity. Okay, so we want to maintain they're ill. Okay, and that brings me up to one point. You know, think about this. Have you ever heard of someone that has been admitted for a psychiatric diagnosis that has received calls from friends? You know, when you go into, let's say you have to have a surgery in the hospital, you get cards. People bring you casseroles. But there's stigma associated with mental illness. It's called the no casserole illness because people don't do that. So maybe we can change that too. You know, maybe you can consider that if you do know a family member or a friend who has a family member admitted to the psychiatric hospital, call and say, how are they doing? What can I do for you? Send a card. You know, I lead a Girl Scout troop, and one of my goals is we're going to make cards for patients in the psychiatric setting. And I cleared it with the hospital. I'm going to bring those cards in. And if someone is particularly not feeling well, they can come up and get a card, or a nurse can give them a card from one of with a picture drawn from a little 10-year-old. You know, this is something to brighten their day. And that's another thing that you want to do is have an overall goal. And the overall goal that I have in the psychiatric setting is to make someone's day better. Do you think that's achievable? We want to have an achievable goal. If I'm going to go in and think that I can solve other people's problems, I'm going to fail miserably. Or if I'm going to go in and say they need to be compliant with the treatment plan, I'm going to be disappointed. Okay? That's not going to happen. But if I go in and say, can I make someone's day better? Every day I'm going to be successful. So I encourage you to have a personal goal. You can take mine or, you know, come up with another, but that's something that's important to have in the psychiatric setting. Okay, I talked about this relationship that it's symmetrical friends or colleagues, but with patients it's unequal. Okay, so we want to have respect for that relationship. Okay, but we do want to consider it complementary, so I do like that word here. You know, one word I don't like is non-compliant, or it's compound word. I don't like that word non-compliant. I'm never going to say that someone's non-compliant because it's really their choice. It's their personal choice what their treatment plan is going to be. So they may be non-adherent to what, you know, the plan is, but that's their choice. So if I have that attitude that it is a partnership, you know, even though I may have more knowledge or I may not be ill. All right. This is kind of an interesting slide to think about, especially in light of all the things that are going on in our country, but we'll just gear it towards mental illness, okay? So there are groups that have more status than other groups, and oftentimes it's what is involved in that is economics. But if we look at how does one group retain power over another group, this slide suggests that it's through biases, prejudices, stereotypes. So I want to challenge you throughout this course to look at your own biases, stereotypes, prejudices, and work through those. Bring them out in the clinical setting. Talk about them with your colleagues. Talk about them in the clinical conference. We'll talk about them in class so that we can challenge those. Okay. The less judgmental we are, the better nurse we are. Okay, so this is something I brought up a little bit already. If we talk about verbal versus nonverbal communication, most of the message is sent how? Nonverbal. So if I was down here and I talked to you in a monotone voice and I gave my whole lecture like this without looking at you, how do you think that would go? It would be pretty awkward, and I don't think you'd be able to pay attention too much. You'd probably want to walk out after 5 minutes. So there's some ways that we can tell someone we're paying attention. There's some ways, like if I asked you, what kind of message do I give you non-verbally? Through my gestures, my tone of voice. What message do you get from me?
Your feelings.
Yes, what kind of feelings do I have for what I'm teaching?
Sad, happy, excited.
But in particular, what message am I giving you right now already that you've gotten from me?
This is interesting.
I'm interested, I'm passionate, I love teaching. I hope that's the message I give you through my tone of voice, not just my words, okay? Maybe my words give you the idea that I'm knowledgeable, okay? But my tone of voice, the way my facial expression is, and my hand gestures, right? Hopefully that's telling you that I'm enthusiastic. You know, even my dress, how I dress is giving you a message. Okay, so we consider that. And that's why I say you should dress neutral in the psychiatric setting, because you don't want the attention on you. That's the whole thing, is you want the attention on the client. Okay, so let's see. Anything else I want to say about that? Okay, and then nonverbal. I just mentioned this. What is my nonverbal telling you? 65 to 95% of the message is nonverbal. How many of us with our significant others have said, you know, it's not what you said, it's the way you said it. You know, my husband might say, oh, sure, go ahead, go on out with your friends and have a great time. Right? It's how they say it, you know. So then I'm feeling guilty. Oh, gosh, you know, don't worry, I'll take care of the kids, no problem. So it's how we say it. So we can have all of these things fall into it. One thing I do want to say is, like, for example, last week when I gave this lecture, I was wearing scrubs, you know. So on one hand, my message is I want to be professional, okay? That was, you know, the overt message. The hidden message that the students didn't know is that I was feeling like I had partaken in a few too many backyard barbecues and I wanted to hide, you know, my body shape in the scrubs. So, you know, even what someone's wearing has a message that you may know or you may not know. But you guys always know that I try to look professional. You see me around here on campus and I always try to dress somewhat professionally. If I came here in jeans and a t-shirt, that would give a different message, you know, but I want to show you that I respect you, that I care about what you think, and so I want to dress professionally for you. And so even the way, and you know how we are about how the students look, right, in this school, we want you to be professional, show that you are, you know, we want you to be a representative of Harbor College, proud and looking good, looking sharp, clean, right? One thing up here is cultural. So which one is that? Or a couple of them are cultural, actually. But one in particular, when we look it up, which one is highly cultural?
Eye contact.
The eye contact. So that's something that sometimes we want to consider culture when we're looking at communication. So if we know that someone's from a high eye contact culture, which is Western, you know, we can expect that same in return. But if we know someone is from an intermittent or low eye contact culture, we would take that into account because we look at that when we're looking at mood, right? So that could give us a message that someone is what? If they have low eye contact and they're from the dominant Western culture, what does that tell us? Might that tell us? Let's say someone is sharing in a group and their eyes are down like this and they're sharing and they don't really look at anyone. Could tell us those things, right?
Distracted by their feelings.
Sure. So those are some of the things, or maybe unsure of what they're saying. So they could give us a message. But if we know that they're from a culture that has a low eye contact as a norm, we may be able to interpret that in a different way. So it's always good to ask too. All right, hand gestures are also cultural, you know. So, you know, what the message that hand gestures say is a little bit different than eye contact. So, and facial expressions, you know, even facial expressions, there's some cultures that are called stoic. Do you guys all know what stoic is? So some, in the Asian culture, in many Asian cultures, the face is not supposed to show expression. So stoicism is valued. So to show you're super happy or to cry is an embarrassment in some cultures. So we have to consider that too. All right. Here are just some other nonverbal communication items in here. Let's see, is there anything else I wanted to hit? Yeah, I think we talked about all of those. So this is just another slide to remind you about that. You know, touch, I think, can be another thing too, and how close people are. Some cultures are also high touch cultures, and some are also no or low touch cultures. So that can be cultural as well. But let's talk about that a little bit for psychiatry in the psychiatric setting. Do you think it's appropriate to touch in the psychiatric setting? So it's very dependent. You know, there are some hospitals, even with the handshaking, because of germ spread, they're saying it's a no contact, which I do like, that it's even a no handshake zone. So some hospitals are catching on to this no handshake zone, which is great for, not spreading germs. But what I say to you, the measuring stick is what is socially appropriate. So if someone puts their hand out to shake my hand in the psychiatric setting, I could say that's very personal if you shake hands or not. Some people don't shake hands, okay, for whatever reason. So if it's the hospital, you can say this is a no handshake zone. We don't want to spread germs. You know, I had a student who said, oh, I do the fist pump. And they would touch fists. But I want to do what's socially appropriate. I normally will shake someone's hand. But now every time I go up to that same person, would I shake their hand? No, it's not socially appropriate. Okay, so you follow social norm when you do that. Now, the thing about touching someone in general, I don't hug anybody that I first meet that I don't know. So I never would do that. And if a client tried to come up and hug me, I would put my hand up and say, or just shake my head and say no. And you don't have to explain why. It's not socially appropriate. Or you can say, no, I don't like to hug. Whatever it is, you can be firm with a client. And you don't have to worry about someone getting angry at you when it's what's socially appropriate. Okay, so you are there to model what's socially appropriate. Okay, so you don't always have to be super nice. As a matter of fact, you don't want to be super nice to everyone. You want to be socially appropriate. The other thing is you have to consider is that some people may be paranoid. Okay, so they may not want you touching them. So you have to be very careful. In a geriatric psychiatric unit, it may be different. Okay, so sometimes you may use what you learned in geriatrics was the therapeutic touch. So you may use that in geropsych. But with clients who have dementia, you also have to be careful. So usually with a client in the psychiatric setting that doesn't have dementia, there's clues that you see that they're agitated, irritated, anxious, and you wouldn't touch someone in that type of situation. But with dementia, people can turn very quickly and be agitated or irritated. So you have to also be very careful with touch for someone who has dementia, okay? Okay, so what do these pictures tell us? So first of all, on this slide here with the crossed arms, have you ever gone into a room and had your arms crossed like this in the hospital when you're going in for patient care? I mean, what does that tell your client, right? Are you open to interaction? So we want to consider that. Where are our hands? And in psychiatry, we always want our hands out of our pockets where people can see them. Okay. How about this person here? How does that facial expression look to you?
Sympathetic.
Sympathetic. Anybody else? Happy. Kind. I think I'd want her to be my nurse. She looks approachable, nice, calm. Okay. How about this? Would we want this person to be our nurse? Yeah. That looks open, kind. Yeah, how about this person? Maybe not so much. Okay, so this slide just shows you, just how you look, can be inviting or repelling. Okay, to be looking at our watch or having our arms crossed, even standing up when someone's sitting down might not be the best way of communicating interest. Okay, so therapeutic communication techniques. They're specific responses that encourage the expression of feelings and ideas, conveying acceptance and respect. There's also another skill to learn, and it's called active listening. And this means that the nurse is using all their senses, sight, smell, touch, hearing, taste even, to be attentive to what's going on with the client. Okay? SOLAR is an acronym for how we want to practice active listening. So we want to sit with the client or stand with the client, but we want to be eye level with the client. Okay? But what about if the client is laying down on the ground, which happens in the psychiatric setting? Would you want to be, how are you going to be eye level with that person who wants to lay on the ground?
Do you kneel down and talk to them?
I don't know. Do you want to kneel down? Do you want to lay down with them? I have seen in simulation students do it. But what's socially appropriate?
For you to stand up and talk to them or sit down and talk to them?
So what would you say to the client? What is socially appropriate? If your friend was laying down on the floor and you wanted to have a conversation with them, what would you say? Or your significant
Okay,
other?
Can I help?
Sure, you could ask that too. Check out what's going on. That's great. And then you might want to say, I want to have a conversation with you. Could you sit in a chair? Okay, so you want to ask them to, and then if they don't want to, that's fine. And then you can say, well, I'd like to talk to you. So if you want to find me, I'm here, or I'll be back later to see if you want to do that. But you're not going to really reinforce behavior that's not the norm. Okay, so you don't want to sit there and have a conversation with them. If they're laying on their bed, that's different. You can sit on a chair, they lay on their bed. But we don't really actually go into the rooms in the psychiatric setting as a student. So follow your instructor's direction on that. Okay, so you want to observe the open posture, right? Without your arms crossed. You want to lean a little bit forward, like I'm leaning forward to you. You're showing interest when you're leaning forward a little bit. Okay, intermittent eye contact, socially appropriate eye contact, and then remember to relax. Okay, so sometimes you have to tell yourself that verbally, I mean not verbally, but silently in your head. I'm going to sit here and relax. I'm going to pay attention to my breathing. I'm going to slow my breathing down. And so initially you may have some anxiety, that's normal. Okay, but you'll be surprised how easily you're going to get comfortable in the psychiatric setting and interested in what's going on. All right. So here are the techniques, okay? So you have the techniques in your textbook, but we're going to talk a little bit about a few of them now. Now, you don't have to memorize the techniques before you go into the hospital. You're going to go in, you're going to have your conversations, then you're going to put them on the process recording, and you're going to look at the tables and say, what did I use? Did I use something that was therapeutic, or did I use a block? And I want to see the blocks on your therapeutic communication. Your instructors want to see the blocks because we want to make sure that you're noticing what you can do to improve your therapeutic communication. If I get 6 weeks of perfect process recordings, I don't think you've learned anything. I would love to see, you know, a blocked therapeutic communication on every single one. And you know what's going to be hard not to say for many people? Why? Why did you do that? Why did that happen? Why, right? So that's a great one to put on your therapeutic communication. And then your option is to and then you want to identify what you could have said. So a lot of times you can say, tell me about the reason that happened, and that's less judgmental, right? So why is considered in many cases that we put someone on the defense or we're asking them for an explanation, and they don't owe us an explanation. So that's the theory behind that. Okay? So silence is a tool that is used for a purpose. So if you have silence in a conversation, that can be therapeutic. If you're collecting thoughts, letting the client collect their thoughts, okay? But if it's because you can't think of what to say and there's silence in there, go ahead and put that down as non-therapeutic. So that one could be either one, okay? Or I was so uncomfortable, I didn't know what to say. Then put it on the process recording and think about something you could have said, okay? We talked about active listening. And then empathy. How about does anyone want to take a shot at explaining empathy? Versus sympathy, right? We're talking about versus sympathy. Because I will tell you, initially, most likely, you will go into the psychiatric setting and you will feel sympathy. Okay, people are going to be acutely ill, acutely psychotic, disheveled, okay? And you're going to feel sorry for them in most cases. Okay, most people do. Okay, so how are you going to move from sympathy to empathy? How are you going to move that? Sympathy is not going to do any patient any good. So we, the nurse, have to develop that ability to be empathetic.
By remaining neutral.
Okay, non-judgmental, neutrality,
and polite, neutral.
polite, having a goal. Okay, let me describe it to you like this. Imagine that you're in a car. The client is in the driver's seat. Empathy is you getting in next to them and experiencing what they're experiencing. So you're going to have them describe their experience, and you're going to be in that car next to them in the passenger seat. They're driving the car. Maybe you need to give them directions on where to go, but that's just through education. And we can make suggestions. That's therapeutic, but we're not going to advise them and tell them, you should take this route, right? We're going to tell them the available routes that they have, give them the information that they need, but they're really the ones that are going to have their own self-determination. Okay, we're partners with them. Okay, so we're going to be empathetic. We're going to try to see things through their eyes instead of looking from the outside in saying, oh, I feel so sorry for that person. Okay, so that's a little bit about empathy. Here's some active listening principles. So remember, this is a good one to remember. Number one, where's the answer? Sometimes the practitioner thinks the answer is in them. But if we remember the answers within the patient, that's going to help us be in a partnership with them. Okay? Some of these are obvious. Objective truth is never simple. Things that go on with us are probably a lot of times not simple. Okay, so we don't have all the facts. So that's one thing I want to bring up is we don't advise someone. I don't give advice to someone because the situation is not simple. I don't know all the ins and outs of what's going on with them. So how can I give them a really good alternative? I can say, have you thought about this? Would this work? What do you think about this? But I don't want to say you should take your medication, you should go to the doctor 3 times a week, you should find a support group. Yes, all those things might be good, but I would rather give the patient the option and say, what are you willing to do? And if you're not willing to do it, what are you willing to do? Or what are the reasons? The doctors seem to think with their education, this is the best thing to do. What's holding you back from that? So we're trying to find out what's going on. Okay, because are they going to go take that medication if they have some bad side effects that their doctor doesn't want to hear about? They're probably not going to take it anyway. So if we can help bridge that gap, okay, that would be great for the client. Feeling confused or uncertain is okay. If you don't know what to say, it's fine to say, I don't even know what to say to that. That's an honest answer. Okay? So you can say that. Okay, and you also have to listen to your gut as well. So sometimes your gut will tell you something and you have to pay attention to that. Okay? So active listening helps strengthen the patient's ability to use critical thinking to solve problems. They're solving the problems. We're not solving the problems for them. But we may be able to bring to the table education, evidence, things like that they can consider as well. Okay? Someone in the psychiatric setting has the same feelings that you or I have. They actually have the same probably wants and desires that we have too, so that's important to remember. Okay? We just treat them like anyone else. Okay, no different. Okay, this is another thing that comes up. What do you think about open-ended versus closed-ended questions as far as being therapeutic? Is one better than the other? Are they both therapeutic? Is one therapeutic and one a block? What do you think?
It's better open for me. Both is okay, but open is better because the patient display everything, the feeling, everything. With the closest, you only have the answer specific, like something.
Right. I like what you said. Both are okay, right? Both are okay, and both can be therapeutic. It depends on the situation. If you have a client that's really depressed, that can't answer open-ended questions, you have to move to closed-ended. If you are doing an interview, an admission interview, you need specific information, right? Although an assessment is different from therapeutic communication, but that's appropriate to use closed-ended questions. So when you have test questions, sometimes you might notice one is an open-ended question and one is a closed-ended question, a yes or no question. Okay? It doesn't mean that the closed is automatically out. It depends on what the scenario is in the question. So both can be therapeutic. It just depends on what's going on with the client. If someone is highly delusional, they may not be able, again, to respond to an open-ended question. Okay, so it depends on the situation. You can use both. Okay, and these are others that are listed in your table. Okay, so if you look at these and, accepting is something that a lot of times if you don't know what to say, you just accept what the client's saying. I hear you, okay. So a lot of times that's what I'm doing, is I'm just listening to them and accepting what they're saying to me. Okay? Giving recognition, you can cross that empathy because I don't really like it there. So if that's, I don't think that's on your slides. But anyway, giving recognition is you're recognizing something that the patient's done without cheerleading. Okay, so you're saying, I noticed that you showered today. I noticed that you dressed in your own clothes today. But you don't say, wow, you look great. You look great today. Woo, you clean up well. Okay, we want to be neutral. Because, number one, we don't want to create a situation where the client wants our approval. That's not healthy. Okay, we're not leaving the hospital with the client. So we want to really give them the credit for what they've done. Okay, we don't want to say, ooh, we're glad you did it. We don't, again, the focus goes on us. So we don't want to do that kind of thing. Okay, the other thing is that someone could have this condition called automatic negative thinking. And if you say, ooh, you look good today, then they will be like, well, what did I look like yesterday? Why are they saying that? You know, what do they want? Okay, so we just want to be neutral. Okay, there's something called a broad opening statement, giving broad openings versus exploring. Exploring is on another slide. Now, a broad opening statement is where the client picks the topic. So they would say, you would say, sorry, what's on your mind today? What do you want to talk about today? Okay, then they're telling you the topic. If you say, what brought you to the hospital? That's exploring. You gave a topic, brought you into the hospital, the reason you came into the hospital. Or how are you feeling today? That's not a broad opening because you gave the topic feelings. Okay, so a broad opening is what's on your mind. What do you want to talk about? Okay, both are therapeutic. Both are therapeutic. Okay, there may be a reason why you want to put something in time and sequence. So you want to show, you're trying to get the client to see maybe something that you recognize was a cause and effect. You know, did you take the drink and relapse, before you got in the fight with that person or after it? Or were you thinking about relapse before you got into that fight? Maybe you're trying to figure out what the trigger is, with a client. How come they relapsed? Okay, so you're trying to put things in time and sequence. Okay, making observations. Okay, this is sometimes when somebody's, very depressed, you do something like making observations. Or even anxious sometimes, I noticed that you're tapping your toe a lot. Do you feel anxious? You can explore after that. Or your facial expression looks confused, or, something like that. You're making an observation. Okay, and sometimes when you can put a label on something, it can help the client, see what's going on more. And also, when you identify, anxiety, then you can take steps maybe to reduce anxiety. So you can make some observations. Sometimes you want to encourage a description of perception. Sometimes people are hearing voices, and you can see that they're hearing voices. And then you can say, oh, tell me what's going on right now. Or are you hearing voices? What are the voices saying? And you can ask that directly. Okay. You might want to compare one thing to another, maybe to also show that two things are related. Was this outburst something like when you were a child? Did you ever feel this way? And you might want to compare. Maybe you're trying to uncover something that happened in the past that triggers a client now.
Where's the line between making observations and being judgmental by saying, oh, you look anxious? Is that being...
You can ask also, you can clarify and say, is that how you feel?
Okay.
And
soften it with the body language and smile or just...
Or maybe you're saying, to me, it's looking like you're feeling anxious.
Okay.
Am I right?
Yeah. Okay.
So you can do more than one. And then I think you know a little bit about restating and reflecting. In the cards, I heard you restating, and then that was the right question when it was the nurse saying, or someone said, I'm feeling something about my parents, wasn't it? And then you just repeated back, oh, bullying, something about the bullying, and you feel like, oh, you feel bullied by, so instead of, so you just you restate what the person says using their own words, most of their own words, okay? I felt bullied when she yelled at me, and then you're saying, oh, you felt bullied. Okay, right? So you're reflecting it back so they'll expand. And then reflecting is a little bit different because you're reflecting back maybe a summarization of the main gist of what you're getting from them. Okay, so reflecting is also you're reflecting something back to them when they say, what do you think I should do? And then you reflect back to them and say, what do you think you should do? Okay, you might say, it's not really important what I think. It's more important what you think. What kind of things were you thinking about when it comes to that? Or I'm not able to answer that question. What about you? Sometimes people ask personal questions and you reflect it back to them as well. You know, are you married? And then sometimes you can say, are you married? Okay, or you just give a short answer, yes, are you married? And reflect back to them. But you don't want to shift the focus on you, so you're reflecting back to get back the focus back onto them. Okay, exploring, we talked about that. That's kind of a general, that's the one, tell me. So when you say tell me, that's kind of, you're always exploring. Tell me about is exploring. Okay, tell me about what happened last week. Tell me about your experience here in the hospital. That's a question I ask all the time. I say, tell me about your experience here in the hospital so far. And then if they give a short answer, I may even follow up with a close-ended question saying, has it been helpful? Or what have you found to be helpful is better because that's open-ended, right? And then I'm exploring too, what have you found to be helpful here in the hospital for you? Okay? Giving information, seeking clarification, I think those are obvious. Presenting reality, sometimes we do when people are have psychosis and they don't know what reality is. They may say to us, you know, I have 20 babies in this bag. I've had someone say that to me. And then presenting reality, I would say, oh, it seems that it would be hard to fit 20 babies in the bag. Okay, now when somebody is psychotic, you're not going to talk them out of it. And so you can choose to present reality, but you're not going to get into any argument with them. Like, so say, for example, they say, I know you hear the voices too. Or you know they're filming us here. You can give information because there are cameras in a psychiatric setting saying, you know, I know they're filming me 24 hours a day. It's the FBI. Okay. You could say, yes, there are cameras here in the hallway so that everybody remains safe. I'm not aware of anything about the FBI being here. It's a psychiatric hospital. We're not associated with the FBI. Okay. And even if they said, yes, you are, that's fine. Just accept it then. Accept it. But you've presented reality and you've given information. So you can say your perception. I don't hear the voices. I'm not aware of that. Okay? And then if they're going to argue back with you, you just say, okay. And you accept what they're saying. Okay? And then I guess I don't need to go through each one of these, I don't think. I will go through just focusing because people confuse focusing and exploring. So I'll just go through those two. So exploring, you know, we're asking them to tell us about something. And sometimes people are saying many things at once. So tell me about your experience here in the hospital. Well, you know, on Monday, you know, the doctor didn't even see me. And then my sister came in, but she was talking to me. I was so surprised she was talking to me because, you know, my brother and my dad won't talk to me. You know, Tuesday, the doctor came in. Okay, they're going over a lot of things. So then you go, okay, let's focus in on Tuesday. Okay, let's talk about Tuesday when the doctor came in. You're focusing them on something because they're having many different topics being presented. Okay. Now let's talk about blocks. Because these are the things you want to put on your process recording, right? Now, number one, yes, it's on your slides here. I don't really even kind of like the whole premise of giving advice on there. I would rather give someone a suggestion and not advise them at all, okay? So I would say if you ever finding yourself saying you should do this, that's a block, okay? So always, should, never, those kinds of words are not something that you should include in your repertoire. Okay, so we don't want to give advice. Okay, so if we find ourselves giving it, no problem. Put it on your process recording, correct yourself. Okay? Minimizing feelings. Okay, that occurs when somebody's saying, you know, I'm really having a hard time with this because my husband won't talk to me. And then you say, well, he'll talk to you. Don't worry. He's going to talk to you. Just give him some time. Right? You're just minimizing. You're not hearing what they're saying. And you're just saying, don't worry. It's going to come in time. So we don't want to minimize someone's feeling. And then again, on the other side, we don't want to be falsely reassuring. Like if somebody said, like yesterday, one of my neighbors has a brain tumor, actually, and she was talking to me about that. And I don't want to say to her, you know, it's going to be okay. You're in good hands. You're at the best, you know, your doctors will be able to take care of this. It sounds like you're going to the best place. I don't know what's going to happen. So I don't want to give false reassurance to someone. You know, I really just accepted what she said and I empathized, saying, you know, you've got a long road ahead, or, you know, you've got a lot on your plate. A lot of times, instead of giving false reassurance, you can just empathize with someone. That sounds like it's a difficult situation, you know. Or I gave information, she was worried about losing her hair. And as a nurse, I know that a lot of people are concerned about losing their hair. So I can tell her, because she said, I feel so silly. You know, I feel so vain because I'm worried about losing my hair with the chemotherapy. And I said, I know a lot of people who have felt that way. A lot of people who go through chemotherapy. So I don't think it's unusual. Okay? We know about asking why questions. So we don't want to ask why. We want to ask it a different way. So tell me the reason, something like that. What makes you say that? How did that come about? You know, just ask it in a different way. Okay? We don't want to ask a barrage of questions, excessive questioning. So you might notice when you're doing that as well. And then we talked a little bit about this before, using cliches. Everything happens for a reason. What are some other cliches? God doesn't give you more than you can handle. So if we find ourselves using cliches, we're going to process those out, right? Okay, so you can think of some more cliches. Okay, the other thing is giving approval or disapproval. Okay, so we don't want to do that either. So it's good that you did that. You know, we don't even want to say that. Remember, we want to be neutral. Oh, I'm glad you talked to the doctor about that. So anytime when you're saying, I'm glad, I'm this, I'm that, I'm proud of you, I'm so proud of you. Look at what you've accomplished this time that you've been in the hospital. You know, we don't want to create that unhealthy alliance. We want to create a therapeutic alliance, a neutral alliance that empowers the client, not empowers them wanting praise from us. And then disproving or disagreeing. Again, we don't want to do that either. Okay, no, I don't think you should have done that. Okay. Changing the subject. Sometimes you may feel uncomfortable with the subject and want to change it. So you have to recognize if you do that as well. So that's also non-therapeutic. Okay, so communication styles. If we look at thinking about, let's say, what is the communication style from, these are your choices, direct or indirect. Stoic too, we can say that. So what are the communication styles of Western culture in general? Let's say American culture, like mainstream American culture. Are we direct, indirect, emotional, stoic? How are we?
Direct.
We're direct, right? Let's compare it to Hispanic culture. Is Hispanic culture direct, indirect?
Direct.
They're more indirect, right? So if I'm going to go and care for someone who's Hispanic and I go in and I want to get right to the problem without any warm introductions, you know, maybe even asking about the family is going to get me in good rapport with a client who's Hispanic, right? Family is important. So if I say, do you have children? You know, are you married? How, you know, things like that, then I'm going to be able to develop some rapport. But if I go into someone who follows Western mainstream culture, I could go in and say, do you have a headache? what is your headache on 1 to 10, right? That would not be considered abnormal, and they wouldn't, think that I was uncaring. They would just think that I was getting to the point. Okay? What about someone, let's say, that's French or Italian? What might we expect from someone like that in their communication style that might be different from Western culture? They may be emotional, use their hands, maybe loud sometimes, And, something that I learned recently from watching, reality TV, I do like to watch reality TV, is the difference between some British cultures, or some British colonies, like, for example, Australian versus British. Does anyone know the difference between something that the British don't do that Australians or South Africans are okay with? The British are very private in their emotions. They don't like to show their emotions, talk about emotions. It's kind of like old school America. Even my grandparents, it's kind of like, don't talk about that. Just sweep it under the carpet. We don't talk about these things. Well, they don't like to get in arguments or fights in public. They do not like to do that. They don't like public conflict. So they will shy away from that kind of thing, where I think Australians are more boisterous and loud, and they don't mind that. Like in America, we don't really mind that either, getting into a public conflict with someone. Okay, so it's kind of interesting. They expect more respect and, what's the word I want to say? Respect and, I don't know, controlled is not the word I'm looking for, but things are much more controlled there. So these are...
Propriety?
Everything proper. So these are just some of the things to think about when we're thinking about it. Asians, like I said before, in many Asian cultures, they respect stoicism. So again, they may not show on their face what they're feeling. So you might have to ask them, and it's more indirect. Okay, eye contact, we talked about that. Perception of touch, we also covered that. And then lastly is cultural filters. And this is a whole topic in itself. But as we're growing up, I don't know about you, but I was what's called egocentric, and felt like, you have this sense that you need security, so you think your culture does everything the right way, so to speak. And then you're exposed to other cultures, and, as we grow up, yes, we can process that and think, oh, everyone can have the right way of doing it. It doesn't have to be my way is right and your way is wrong. But some people still do, as they grow up, have that sense. The way we do it is right. That one is wrong. And so they're not really open to looking at other cultures. So in nursing, of course, we want to learn about other cultures. We want to see what we can bring in that will help them, their quality of life, their sense of well-being, by incorporating culture into the treatment plan. And so that may happen also in the psychiatric setting. We want you to look at that, and we'll talk about that in a whole another level when we have a whole chapter on culture. But what we want to know is that we do have cultural filters. Each one of us has cultural filters, and my eyes have been opened recently to a cultural filter I really wasn't, I guess I was a little bit aware of, but what's going on in our country recently has opened my eyes to white privilege, that I have white privilege. And I really wasn't totally cognizant of that, but now I'm very aware of that, and I'm exploring that in myself right now too. So cultural competence, there is no end to the destination. It's a journey, and you can always learn more. So we will be really looking at culture in the psychiatric setting. Okay, and we want to make sure that as best as we can, we address bias and prejudice. Okay, so the mentally ill are highly stigmatized. They live on the corners and outside edges of our society. They are not brought in, to the mainstream. So how can we change that for ourselves? So we're going to be working on that as we explore our own prejudice and biases, okay? If you want to do this for yourself, you can kind of go through these and say, how do I compare this with another culture and my culture, okay? Is my cultural filter different from others? Yes, of course it is. So we can do this exercise and see that. Okay, so what do we want to do in therapeutic communication? Okay, we want to be neutral. We talked about that. But doesn't everybody want number one? Okay, so a patient in the psychiatric setting, we're going to try to help them feel understood and comfortable, safe. we want to have them feel they're safe to come to us to discuss something. We may want to identify a problem and explore that with them. Maybe there are some healthy ways that they could meet their emotional needs. So we may even suggest things, but not advise. Okay? And we want to have a satisfying interpersonal interaction with them. I can't tell you how many times that I've heard someone say to me, wow, someone really hasn't listened to me like this for a long time. Okay? So just you being there in the psychiatric setting as a student, we're going to talk about something called a therapeutic milieu, and that means a therapeutic environment. Students bring such a great piece of themselves to the hospital, and it creates a great therapeutic milieu, and they want you there and they want to talk to you, and you bring a positive addition to the therapeutic milieu. So you make the hospital better when you're there. And you make the patient's experience better when you're there. So I love bringing students to the psychiatric unit, you know. And the patients appreciate you. These things talk about preparing for your psychiatric interview. Okay. So you want to go at a pace where that's appropriate for someone. For example, if someone has depression, you have to be patient. Their communication rate may be slower than normal. You don't want to try to finish their sentences for them and move them on. So you have to consider your pace, where the setting is. We want that to be private, if we can. Our seating arrangement, and also the way we face someone is important. We do not want to be in a confrontative stance with someone. So even when I'm standing in the psychiatric setting, you'll always see that I stand at an angle to a patient. I never stand face to face head on to someone, because that's confrontative. So if you're standing with someone, you want to stand a little bit at an angle. And then if you're sitting with them, this is a funny thing in the psychiatric setting, because the chairs are so close together, they're like attached. So sometimes you do have to be right in someone's personal space, and you're talking to them right here, and you can't do anything about it. You know, but then it becomes a norm. You relax a little bit once you're seated in that situation a while. But, you know, you're face to face, you know, leaning forward a little bit, maybe leaning towards them a little bit. You always want to let a person know who you are. Okay, I can't tell you how irritating it is when I don't know who I'm talking to in the hospital. Now we have big badges, at least that say RN. But, you know, I don't know about you, but my badge always gets flipped back. Never the front is out. Why is that? Why is the front never out? It always gets flipped to the back. So I like to tell someone, I'm the nursing instructor. I'm constantly saying in the hospital, because they think I'm an employee, oh, I'm a nursing instructor. I have my students here in the hospital. So I always try to, you know, tell who I am. Okay. And then how would they like to be called? You know, so we want to find out, would they prefer to be addressed as Mr. and Mrs., or sometimes they might say to you, you call me, you know, MJ Hammer, you know, are you going to do that? What if they say, call me Dr. Jones? You know, and you know that they're not a doctor. Well, the book answer is, you know, you're trying not to reinforce something that's not reality, but it depends on how much agitation it causes the client. If they're going to be super agitated, then you may go along with it for a while. But you may just bypass it and try not to address them in that sense, you know. So, you know, you really want to do what's socially appropriate, unless it's so agitating to them that you're just going to say, okay. Okay, initiating the interview. So I talked about that. It's the short bursts of interaction in the morning, and then you can actually say, hey, can I have you come over here and let's talk for a while? And then those broad opening things, you know, what would you like to talk about today? And then they'll be like, well, you sat me down here. And then you could say, okay, well, how have things been going for you in the hospital? You know, is there anything that you found helpful here? Something like that. So you can just start about, you know, their experience in the hospital, or something they said in group. Okay. Here are your attending behaviors. One thing I guess I would say too, you want to keep, you know, your hands right. They're not going to be in your pockets. They're going to be out in front of you. You're going to have an open posture. Okay, encouraging gestures, meaning nodding your head, showing you're listening. And here are some other helpful guidelines. When we're in the hospital setting, you know, how close is it when you first meet someone that you start to feel uncomfortable, do you think? How many inches do they have to be to you? Shall I get up and walk and see how comfortable you are? So if I come over here, and I start coming near you, tell me when you're comfortable.
Uncomfortable. I was uncomfortable with you back then. As soon as you got that expression on your face.
Yeah, I'm talking to you. It's about 12 to 18 inches, right? That's our intimate zone. And so we're going into, and as a nurse, we go right into the intimate zone every time. So we just have to respect that, you know, that we're in that intimate zone and realize that we are, okay? So we're a little more comfortable when someone's a foot and a half away and beyond. That's a social space. That's our social space. I'm sorry, that's our social space is 4 feet to 12 feet. Personal space is 18 to 24 inches. So we feel more comfortable when someone's 1.5 to 2 feet away from us if we don't know them. This slide talks about clinical supervision. So it's always great when you can have a mentor, especially when you're experiencing some type of feelings about something that you may not sit right with you. So let's talk about how you're feeling in the clinical conference, okay? And then we can all help each other. But having a mentor, this talks about clinical supervision when you're uncomfortable with any situation in the hospital. It's always good to check with a mentor, a teacher, or someone that has more experience with you than you. Okay, process recording is what? It's our buzzword. That you know, you're going to find Mrs. Moore's favorite term, evidence-based. Okay, it's evidence-based to help you improve. So we're going to want you to do that. Here's a couple of ways that you can initiate a therapeutic conversation with someone. So we've given you a couple of techniques that you can look at. One here is called the bathe technique. So if someone has a problem, you can use this bathe technique, okay? And here's another thing that you can do is name the emotion. Another technique, nurse, name the emotion. Give empathy. I can see how you would feel that way. Respect is another state of empathy. And support. And then go into what the issue is. Okay. The last thing I want to talk about is informatics. It's fascinating what's going on in the medical setting in health informatics. Okay, the one thing that's going on specifically in the psychiatric setting is therapists are seeing patients via Skype. Okay, the barrier to that is insurance reimbursements, but they're catching up. So it's very helpful, especially if someone lives in a rural setting and they live far away from a therapist, that they can see their therapist on the computer. Okay, but another thing is like being able to get out of the house. If someone has a highly acute psychiatric condition, it may not be so easy for them to actually remember their appointments, get on a bus, get to the appointment, things like that. It may be difficult. So it may be being the wave of the future, make things easier and help people access care better. So it is coming, and it's coming in more ways than that. You know, we know about robotics and how people can conduct operations remotely. Right? So that's even happening. So there's so many fascinating things that are happening, okay, with telehealth and telemedicine. Okay. Another thing I wanted to talk to you about, a stigma. People are afraid to go in for treatment. So that's another way that it may be easier for them to be in the privacy of their own home to obtain treatment instead of going in and sitting in a psychiatric office and being afraid and feeling stigmatized. You know, it's another barrier to achieving care. So we can break down some barriers through telehealth and telemedicine. The other thing I do want you to look at as you go through the setting, and I'm going to ask you to do this on your H&As, is finding apps and finding resources on the internet for clients. Okay? For example, there's something called the Depression and Bipolar Support Alliance. And this is a internet-based resource that you can give to your clients. You know, where can they learn more about their disorder? Where can they find support? And so through there, they can find support meetings that they can go through that aren't necessarily, that won't cost them money. You know, that they can go get support from peers. Okay, we'll learn about Project Return, a peer support network, which is really important for clients to get hooked up with. They have groups all over California, Northern California, Southern California. They have groups all over. NAMI is another organization should be telling all our clients about, the National Alliance on Mental Illness. So we want to be telling our clients that we are in the computer age. Everybody has a smartphone pretty much, you know. So if we can hook them up to internet and community-based resources, that's great. And then apps. We're going to explore some apps, and I want you to explore some apps. Even in medicine, therapists are having clients upload an app onto their phone. They have a code, and then they're treating the patient through these apps. Let's say the patient is feeling high anxiety. They can go on the app and they can say what their symptoms are, and it gives them ways to calm themselves down, you know, through these apps. Okay, so these are really great things for them. There's also something like, I'll teach you, it's called My3, and it's for suicide prevention. Sometimes if you're suicidal, you're not thinking about how you can solve the problem, but you've pre-thought it before, and you've put your plan on My3. And My3 stands for the 3 people you contact in case of feeling suicidal. Okay, but there's other things in there. It talks about your coping mechanisms, you know. And so you can look on that when you're feeling distressed and have that plan in there for yourself. Okay, so what apps can you show your clients that will be helpful for them? There's many meditation apps. There's tons of different apps that are helpful. If you just plug in depression, you'll see all the apps that'll come out. It's up to the nurse to tell the patient what's appropriate. You need to be able to look and discern, because they may get an app that's not really good for them. Okay, or they may be looking at an internet site that glamorizes suicide or anorexia or something like that, right? And then you, the nurse, knows, oh, that site, I know that that's where, you know, teens glamorize anorexia. You know, I know about that site. Okay, so that's something that I want you to be aware of. And gosh, it's going to go more and more. There are, you know, EKGs that can be done on the smartphone instead of plugging someone up. There are scans, you know, there's a heart scan. A doctor can have a program on their phone and they can do scans on people. So there's so many fascinating things. I can't even talk intelligently about it because I don't even know all what's going on there. But it is the wave of the future. It is fascinating what you can do via telehealth, just a simple iPhone. You know, there's a lot of apps that even doctors use for diagnosis, okay? So that's something that we need to be up on. We need to be up on these things as nurses, okay? And so these last slides just talk about it. And of course, the Department of Defense was ahead of the game on these things, okay? So they are really looking at that for their clientele. You know, you've heard about the problems with veterans getting into for psychiatric services. So they're really looking at this for that. And so it should be helpful, and maybe they'll lead the way, and it's our dollars, you know, funding this, but maybe that's going to lead the wave for the future for all of us. Okay. There's just some of the examples. You know, this touchscreen mood map for Android and iPhones invites users to plot mood during the day and view trends, and then their provider can see that. You know, how many days of the week have I actually been depressed? You know, and that can be tracked. So things like that. But you have to participate in them. There's something we'll learn about called cognitive behavioral therapy, and this first one talks about a phone app that helps you. So you're learning it when you're with your practitioner, but then this mirrors it for you and reinforces it. How do you use cognitive behavioral therapy? And what it does is help you change your thinking and behaviors. Okay, so there's lots of stuff that's out there, but this is the barrier like I talked about. Okay, Medi-Cal and Medicare are paying some for these services. Okay, the other insurances hopefully will follow. But it's all just starting. So if you're a technological genius, you can maybe get on the bandwagon and create some stuff, you know, too. All right, let's go through the questions here and see how we're doing. As a nurse assesses a new client, the nurse makes sure the door remains open. We really didn't talk about that, but you always do want to keep a way, if you can, for both people to get out. Okay, so it's great if you can have both people able to leave the exit. Both people able to leave the interaction. But if there's only one way out, you want to make sure you're the one who can get out in case of behavioral crisis. So what type of communication factor is that? Environmental. Has to do with the environment. Doors, right? Okay. All right. A nurse assesses a newly hospitalized client. Which communication technique will the nurse use most? The key word in there kind of goes with it, and I did talk about that. So assess is our key word. In assessment, you use what mostly? B, closed-ended questioning. Okay, right? And assessment is not therapeutic communication, but that's when you're asking a lot of closed-ended questions. All right. Okay, so that is the end of our slideshow. Does anyone have any questions? I have some more questions we can go through. If you want, I have some questions up here. Let me get them up here. All right. If I mirror this, I think I got to do function 8. Function 8. I'm going to duplicate this. Okay. And I have these handouts here too. Did I give you this handout that has the questions on it? Oh, maybe they're right here. Here they are. All right. So let me pass these out to you, and we can go through these questions. All right, so there's some questions here. Let's see how we're doing. Okay, so here's the questions. So here, Sid is a 70-year-old male who has multiple problems. Today he states that he is feeling badly with a new problem. The nurse needs to find out what the problem is. What type of communication is best suited to finding the problem? He's feeling bad with a new problem. He has multiple problems, right? So you're right, D, focusing. So he has multiple problems, and so we're going to focus in on what the new problem is. So that's correct, D. Wanda is a 67-year-old woman who is having a hysterectomy. She confides in the nurse that she is afraid that her husband won't find her attractive anymore with scars and not being a real woman any longer. The nurse states everything will be fine. He won't care the slightest. What has the nurse done?
Minimize your feelings.
Exactly, minimizing. The nurse's patient is diabetic. The patient's family decides to celebrate a birthday in the hospital and brings cake and ice cream. The patient can't have these, and the nurse states to the patient's spouse, "How can you bring these things into your husband's hospital room knowing he can't eat any of this and is sick?" The nurse has done what? Exactly, C, value judgment. So that's kind of a situation that might make a nurse feel what? So you're in there with your diabetic patient and the family brings in cake and ice cream. How are you going to feel as a nurse? Yeah, upset. We might feel like mad. Okay? So we have to figure out a way not to display that and affect change. So we may want to give information. We may even say that's not allowed here. You know? So we may have to draw some boundaries.
Start teaching.
And so there's a way to be firm and kind. And I think sometimes students are afraid to be firm in a situation. And it's okay. Sometimes you have to be firm. And so sometimes the answers on the test are going to be firm and you're not going to want to pick them because they're firm. But sometimes we do need to be firm, and it's hard for us to be firm. But that we could say that's not healthy for the client. We can't allow it in here, or I'm not going to allow it in here. You know, if you guys want to have it, you can have it in the lounge, something like that, okay? The nurse understands that they need to acknowledge their patient's pain. Which statement shows the nurse understands this principle? So it's saying, so we have to look at the key word in the question. So it's asking us, how do we communicate that we're acknowledging their pain? So we're not really exploring their pain, right? We're acknowledging that they have pain.
And this is in reference to the psych patient, right?
Yeah, I don't have the answers to these, so we're figuring them out together. So we have to look, what's the key word? Acknowledge pain. Which statement best shows the nurse understanding of acknowledgement?
Tell me more about
Yeah, the only one that's saying acknowledging it is really, I think, C, because you're saying it's real. Although the question is not telling us that the patient is psychotic, but that's really the only one to me that's actually acknowledging the pain itself, that it is real. So I think it's C. If we wanted to explore the pain, of course it would be A.
arm. They don't specify what.
Yeah, when you say,
These would be kinda like
when you
low
said your
base.
arm hurt, it's still not acknowledging, right? What does the word acknowledge mean? That's the question.
But they
When
don't
you're
say
saying it's
about
real.
where is the pain in the arm?
Would D be more like explore, I'm sorry, focusing? D?
I think it's clarification, D. D is clarification,
Okay.
not acknowledgement. So to me, C is acknowledgement. Okay, number 5. Pat has learned that she is dying. Pat starts to cry. The nurse understands therapeutic communication when the nurse, now this is just therapeutic communication overall. I think this one is more obvious. What do you think on that one? What do you guys think? Anybody?
I would say.
Let it see.
I would say D.
See?
Ooh, we're all over the map. The answer is A. Okay. So the thing is, ask a clarifying question to, yeah, the thing,
But why, you said,
you know what's making her sad.
why she's crying? But this
But
is
why,
about
you're
us.
not saying, why are you crying, right? So the clarifying question would be something like, tell me about your tears. And I use that all the time. So this is the thing, is that we know why she's sad, she's dying. But we want her to talk about the feelings that she's experiencing. So I think you want to clarify, the nurse leaves the room, we don't want to do that. And we don't want to allow her to cry on our shoulder, because that's like crossing, a boundary. And so what exactly is making you sad? Well, I'm dying. So I wouldn't say that, So I would say something like, tell me about your tears. Or do you want to talk more about it? And so that's more of where I would go.
Don't ask why.
But we're not, I know that, the problem is that says why in it, so that would throw you off. But you're not going to say, why are you crying? That's the same thing. That's the thing is saying, why are you sad, right? Tell me, how come you're sad? We just want to open it up more. I think maybe the question could have better be written saying, asking, exploring questions about the reason the patient is crying. Yeah, we'll throw it out. All right. Let's see, our next question here is, the nurse needs more information to clarify exactly what the patient needs. Which statement shows the nurse understands this principle? We don't have any. That number 6 doesn't have the responses. So we'll move on to 7. Our own value and beliefs can put us at odds with patients that are not living the way we think they should behave. Of course. Yeah, it's kind of interesting that, I have a doctor that I work with that says, she tells me I have 2 prejudices. One is people who are grossly overweight and another is tattoos. So that affects her, but step 1, you're aware of it, but now what are you going to do about it? So that's for us, our job is step 1, what are our prejudices? And how are we going to, doesn't mean we have to accept it or change our view, but we just have to be able to move past it and give care in a non-judgmental manner, right? So that's what we need to do. All right. Stan is a new nurse. He's very concerned about getting his tasks done. He walks in on a patient who was looking out the window. Stan asks, "What's wrong?" The patient answers, "I'm old and my body is wearing out." Stan replies, "Nonsense. You aren't that old, and you just have a kidney infection." What has Stan done? We kind of already answered this one before. So when he said nonsense already, that's minimizing, right?
Mm-hmm.
The nurse realizes that the patient is having a hard time dealing with their diagnosis. The patient states that he is feeling alone with no one who understands. Which type of communication could be the most useful for the patient? Yeah, I think so. B, let's step in there with them. Yeah, let's step in there and empathize with them. Nobody understands. So can you help me understand? I would like to try to understand. Can you help me understand? Kelsey is a 17-year-old who has decided to have an abortion. The nurse does not agree with abortion. Kelsey is afraid of the procedure. The nurse, who is infuriated by the patient's behavior, does not make eye contact with Kelsey. The nurse goes in and out of the room and looks annoyed and only answers questions with a simple yes or no. The nurse has done value judgment. So there are some more on the top of this. You can cut and paste, and actually the first cut and paste, if you want to just do a couple more things that there's some good communication exercises at this Community College of Austin, Texas. So for example, now let's, like for this, you guys are going to know which ones are the right ones. So which one is effective and which one is ineffective or a block? Asking an open-ended question, where shall we put that? Effective? All right. Provide broad opening. Which category? Effective. Okay, reassuring. Ineffective. Okay, restating. Effective. Advising. Ineffective. Interrupting. Put it over here. Reflecting. Effective. Focusing. Effective. Exploring. Blaming. Requesting clarification. Effective. Asking yes or no questions. We got to put it somewhere. Where do you want to put it? Effective. Ineffective. We've got 2 effectives and 2 ineffectives. You're a tiebreaker, Maria.
In effect,
Ineffective. So we'll put it over ineffective and see what it says. Probing. Would you want to be probed? Think about that. Just the word itself. Let's put it in ineffective. Probing means that you're going too far with your questioning. Okay, changing the subject.
in effect,
Ineffective. All right. Sequencing events. Effective. Parroting. Silence. Summarizing. And belittling. All right, let's check our answers. We got them all right. So there may be times to ask yes or no questions, so you guys actually did, by consensus, put it in the right one, because initially I think that you wouldn't want to start off with yes or no questions, so you could put it in ineffective. Now, parroting, there is something that is an effective technique that's not necessarily parroting, but it's called sort of. It could be mirroring, and that's one that's close. And then remember the restating. Okay, right? So there's a way to do it where it's therapeutic, and then if you just keep parroting back what the patient says again and again, it's going to get old. So you have to be careful. You can use it once or twice, but if you keep doing it, then it's going to be parroting, and then they're going to get irritated with you. All right. So that's that exercise. And then there's one more on here that we can do it now, or you guys, what are you feeling like? You want to do it now, or do you want to, are you needing a break? Don't worry, it's not going to be on the tape, this part. Okay. Did I put it? I don't know if I put it there. So this one is kind of cool. I really like this one. So this one, it says for each of the following statements, they're going to say which responses are appropriate, and I think there's 3 responses per scenario. Okay. So since I got my leg amputated, I can't do any of the things I used to do. I have to sit around like an old man and have people wait on me. Do we want to say it's been really hard for you not being able to get around like you used to? You don't want to say it? Do you want to say, it's all pretty new to you now, you'll be able to get around more than you think? This is therapeutic communication, not your friend. If you keep talking like that, you'll just make yourself more depressed. Okay, that one is a no. Tell me more about the things you're not able to do for yourself. So some people are okay with that one. You're feeling like an old man because you think people have to wait on you. So is that okay if we're repeating what they said? There's 3 right answers here. Okay, there's one more. Which one do you think out of those is the right one? The last one? It's normal to feel like that at first. Once you get your prosthesis, you'll be up and around like usual.
But that may not be true.
False reassurance. That's false reassurance.
And then it's all pretty new to you.
It's all pretty new to you right now. You'll be able to get around more than you think.
You still may not be.
False reassurance. Number 1 is empathy. Let's check on it. Let's see. So then we have to, oh, it's correct. So see, correct has come up. So these are things that you may say to your loved ones. Okay, you may say in a social situation, but as a nurse, you're not really listening to what the client's saying. You know. Okay, I just don't understand why my blood sugar is 280. The only bad food I've eaten was some homemade biscuits. You're confused about what your why your sugar is high when biscuits were the only food that you ate that you shouldn't have. You're just reflecting. So you're saying the same thing. Let's explore what you mean by bad food.
That's good. Let's explore.
It's good. Your blood sugar is not under control. You must be eating some other things that you shouldn't.
No, this is a
You sound pretty alarmed. Don't worry, we'll be able to bring it back down. It's good that you're concerned. Let's see what we need to do to get it down. Your sugar is high even though you've been trying to control your diet. Maybe the dietitian can help. Which one is the best one? There's one more. Which one is the most neutral?
Third one.
The third one is neutral. The last one. Let's see if it's right. Correct. Okay, so this helps you with testing, right? This is, you're picking the neutral, non-judgmental. We want to say it's good. We want to say some of these things. Okay. Do you really have to draw more blood? I'm tired of being used for a pincushion. You people won't even let me sleep. You will hear this. Definitely. It's upsetting not to be able to get any rest. Things sound unusual when you're first starting therapeutic communication, but is this really giving the gist of what the patient, are you empathizing? Are you seeing what they're saying with this statement? Yes, you are. I'm sorry we have to keep sticking you, but the doctor wants to see if you have an infection. Is that neutral? Not necessarily. You're upset because we keep having to stick you and you can't get any rest. Okay, nodding heads. It sounds like you haven't been, oh, they don't like that one. Is that why it's doing that? Nope. It sounds like you haven't been getting much rest. Let's talk about how you've been sleeping. You like that one? I'll come back in a little while so you can get some rest. You're tired of us disturbing you and having to stick you to draw blood. I'll talk with the doctor to see if there's something we can do differently. Okay, you like that one? Excellent. I thought this medicine would have stopped my diarrhea by now. The doctor doesn't know what he's talking about. Give it some time. I'm sure if you wait a little longer, I'm sure it'll work if you wait a little longer. No. He's a very fine internist. The medicine is commonly prescribed for diarrhea. This is called, like, where you want to stand up for the doctor. So we don't want to do that too. I mean, I don't like to put it in those terms, but we don't want to kind of go on the defense. Yeah, go on the defense of the doctor. You're discouraged because you were hoping it would have worked by now. Neutral. Neutral. Very neutral. You're upset right now. Let's see what we can do to make you more comfortable. Nope, don't like that one. You're concerned because you're still having diarrhea even though you've started the medicine for it. Okay, nodding heads. And then last one, I can see you're upset about your continued diarrhea. Let's talk about some ways you can express those concerns with your doctor. So we know that's it, right? All right. Is it really 12? Is it 12:21 or is it 11? Is this clock right? Okay, good. All right. Okay. All right, almost done. My daughter said I could come live with her until I recover, but she's got a husband and 2 kids to look after. You don't want to go live with your daughter because you think it might be a burden to her? No, you want me to go down? It sounds like she really wants to. It sounds like she really wants you to live with her since she asked you to. No. You're unclear as to whether it would be a good idea since she has a husband and kids. Okay, we like that one. Okay. You shouldn't feel like a burden. Your daughter and grandkids love you. Okay, but this is a lot of times what the nurse will say. I mean, and students will say this too, right? It's hard when you have to ask others to help you, but it will only be for a short while. No. Say some more about why it might not be a good idea to live there. Let's try it. So we have one more. Now we know you shouldn't feel like a burden. We see the word shouldn't. We're going to throw that one out. Which other one do we want? It sounds like she really wants you to live with her since she asked you to. I don't know. That's kind of, we can't really assume that. That's kind of an assumption, right? So which one could it be? It's hard when you have to ask others to help you, but will only be for a short while, or you don't want to go live with your daughter because you think it might be a burden to her. We'll try the burden. Okay, we'll try it and see. Correct. All right. So I hope that helps you and gives you, some idea of how to do that. Certainly it's going to help you with your tests, and we thank our guests who came in to help us. You made our lecture much, much better. So thank you for coming.